Good afternoon. Thank you for the invitation to participate in this symposium. I'm Dr. Larry Diaz, and I work in Kalamazoo, Michigan. I'm going to talk about extravascular ultrasound guidance for interventions in patients with CLI. We start with this sculpture that signifies the tibial axis. We'll start the first case is angiosome mapping a 55-year-old male with history of type 1 diabetes, a cranial of 5.6. It has this ulceration spanning both the dorsal and plantar aspects of the foot, which corresponds to the angiosomes of the AT and PT. When we do the angiogram, we confirm the findings with a subtotal occlusion of the PT proximally with reconstitution distally, as you can see with this retrograde cap. And we confirm with the ultrasound. The AT distally also has an occlusion with reconstitution as an island in the dorsalis pedis, which also has a retrograde cap. As we know, performing a CTO cap analysis based on the CTOP study, we can see that the retrograde cap favor a retrograde strategy, which is what we ended up performing for this particular patient. So also happens in the AT with both retrograde concave caps. So we perform here retrograde ultrasound guided access of the posterior tibialis. We start in the transverse view. As you can see, the needle is bouncing from the wall of the PT, which is heavily calcified. So we continue to what I call dance with it until we get in. And once we get access and we start putting our wire, then we switch the ultrasound to the longitudinal view to visualize the wire as it penetrates into the artery. And we are allowed to then rotate the wire back and forth. And then we were able to finalize the wire ring of that PT. As you can see, the sheath is already here in the PT. And now we're proceeding with access into the anterior tibialis. Then we pass the retrograde wire into an antegrade catheter that we have from an antegrade ipsilateral access on the common femoral. It says people calls it rendezvous. I used to call this synapsis. And here you can see the synapsis or the passage of the retrograde wire into the antegrade catheter in the ultrasound view. Then you reverse the axis and proceed with intervention in antegrade fashion. Here we're performing ultrasound guidance, orbital atherectomy of the posterior tibialis in the entire course. Here's a sped up. Then we proceed with angioplasty of the entire segment. And then we do the exact same thing on the anterior tibialis side. And this is the final angiogram with reconstitution of the arch. This was the original wound. Follow-up at a month already shows healing, and 2 years later is actually completely healed. Second case is the same patient, his left foot. We made a CO2 angiogram to look at the inflow vessels. All of them were open until you get into the dorsalis pedis, which is missing. Then we proceeded with antegrade access of the tibial and the anterior tibialis distally to be close to the wound, to the area of the lesion, in order to have more torqueability, pushability, maneuverability, and in order to have to use less contrast in the event that we had to use contrast. Here's the sheath, and here's again the dorsalis pedis missing. I'm using a Treasure 12 wire, as you can see here. It's not penetrating. You can see the tube of calcium that artery is. Then I injected CO2, and you're going to see how it diffuses quickly into the capillaries around the total occlusion, given that the CO2 has high diffusion capacity. I was able to actually switch the wire to an 18-gram wire and a support catheter, and I was able to cross. I injected 2 cc's of dye to show that, then proceeded with progressive angioplasty from distal to proximal. And with 4 more cc's of dye, I showed that I was able to reconstruct the arch. So a total of 6 cc's of dye. Here's the final picture with the ultrasound on CO2. And this is the CO2 bubbles passing through the lumen of the patent dorsalis pedis. That's how CO2 and ultrasound allows us to do these interventions. This was the original wound. A month later, it was completely healed. Third case, more challenging. Patient with coronary disease, bypass, hypertension, diabetes, hyperlipidemia, and PAD. Already had an aorta bifin bypass graft and presents with rather forced symptoms. The diagnostic angiogram showed an occluded osseo SFA until the Hunter's canal with occlusion of the AT and the PT and a significant lesion in the tibioperineal trunk. Here's the occlusion in the SFA at the ostium, the bifemoral bypass graft, the reconstitution at Hunter, and the about 70% lesion, I would say, in the tibioperineal trunk with occlusion of the AT and the PT. There's distal reconstitution of the AT, which we utilize for a retrograde access. Here we have our wire penetrating in retrograde fashion. We perform a retrograde angiogram. We allows us to see that the occlusion wasn't as long as we thought. Okay, it was only that the antegrade column of contrast was not penetrating the cap. So we utilize again our ultrasound, and here we're passing this as a V18 wire is going by itself through how the AT. And here we're going to see how we hit the occlusion. You're going to see how we see when the wire gets stuck as right there, we redirect it and cross the occlusion, which was, as you can see, located in this area. Then we continue passing our wire. Here's the curve of the AT into the P3 segment. And we cross our popliteal segment. Now we change the wire for a Navicross catheter. And here you can see how we have the Navicross catheter going through the popliteal into the SFA. Once again, when we find occluded segments, we're able to manipulate our catheters and make them get through. Here, it passes into the common fem and into the iliac. And as you can see here, this is going to be the catheter. When it hits the plaque in the common femoral, you see we're getting underneath it. So I pull back and then I redirect the catheter. I torque it upside, as you can see here, and then downwards, passing those two segments of plaque from the common fem into the iliac vessel. So now that we crossed, we perform our ultrasound, which allows us to see the size of the vessel and therefore allows us to properly size the balloon. This is all being done from the axis that we have in the foot. And then to stent, I utilize a slender sheath 5/6, which I only put the tip in the foot to pass the shaft into the vessel. And then I remove the sheath as I'm performing this deployment of the stent. And this was our final result with excellent flow. I performed angioplasty throughout the AT. And this was our final picture. And we performed ultrasound evaluation of the site of access to make sure we didn't have an occlusion. As you can see, we have nice biphasic flow. Our last case is a retrograde transtibular intervention from the AT to the PT. We form our wire in a proper fashion. Here we have the angioplasty, which is the dug bone, and you can see the calcium on the ultrasound. Therefore, we utilize our CSI orbital atherectomy. You can see the contact directly against the wall. We perform several passes, and then we follow this with our angioplasty, which now expands fully and allows us to show that we're going to recover the plasticity or the latency of that artery, which was previously without any motion due to the heavy calcification. So in summary, ultrasound-guided retrograde access and interventions allow us to safely and effectively treat this CTOs and CLI patients, given that it allows us to directly visualize all the devices that we're using, from guide catheters to wires and atherectomy devices, et cetera. A pre-planned antegrade and retrograde strategy for the treatment of lung CTOs is actually based on science that has already been published. Thank you very much for the opportunity to share with you. Any questions, I'm happy to answer. That's my email and my cell phone. Thank you.